Hey guys, so this session is about pediatric dentistry and it's chapter 57 from your Modern Dental Assisting Textbook, edition 13. That's a big fat purple book. And today we're going to talk about pediatric dentistry. And you can see that in your Modern Dental Assisting Textbook on page 890. So feel free to look onto that we as we go over it. So I'm going to go ahead and put the slideshow on. And let me see if I can get that go. There it is. Okay. All right. So we have some objectives here. And some of the objectives are we want to know the appearance and the setting of a pediatric dental office. We want to discuss what the pediatric patient is about and explain why children and adults with special needs, because that's a little bit tied into this practice, and how they're treated in the pediatric practice. And we want to discuss the types of procedures that are performed with those to treat patients with permanent teeth as well. So pediatric dentistry on the whole is the specialized area of dentistry limited to the care of children from birth all the way to adolescence and those with special health care needs. So emphasis is really on preventing, early detection, diagnosis, and treatment. But overall, the pediatric dentist, what they have to do is they have to do an additional 2 to 3 years after they graduate from dental school. So it's kind of like a specialization. So whenever you go to dental school, you do something more like it's general, and then once you're done with that, you do 2 to 3 years, which then deals with you getting more specialized with this type of field. There's also a pediatric assistants, and many are employed by expanded duties, and it depends on the nature of the practice. So you'll be doing more sealants, fluoride, radiographs, etc. The office is more child friendly. There's more of a cheerful display, things that are just non-life threatening. You'll see a lot of cartoons, a lot of I guess you could say trinkets or dolls, so to say, or even puppets like you see here in the picture. And there's more of a colorful ambiance, and the dental personnel tend to dress in bright colors just to give that feel. And this is a typical example of a pediatric office. And this is also in your textbook, I believe on 891 in your textbook. And as you can see, they're very open bay areas. As you see here, there's lots of open bay areas, and it's more of a colorful aspect, and it's very roomy also. But when you deal with pediatric patients, you have to consider the chronological age and the mental age that goes with it, as well as the emotional age. So the chronological age is the actual age, right? From whenever you were born to if you're 2 years old, 3 years old, in a couple of months, etc. But the mental age is different, and that deals with the intellectual capacity. When it comes to an emotional age, that deals with the child's level of emotional maturity. And there's guidelines for patients' behavior in the dental office when you deal with that. Your book talks about the Erickson stage of development, okay? And in that development, you have to first consider learning basic trust, and that goes anywhere from infancy through first year. And then there's learning autonomy, so you go through your learning skills all the way to 2 years old. And then there's like a play age of 3 to 5 years old where they're starting to develop self-control. And then there's the school age. And then there's school age, that's from like 6 to 11, where they're dealing with socialization, how they socialize with others. And then, of course, the good old adolescence age from 12 all the way to 20. And that's when they acquire self certainty. So you see, it's quite, I mean, I know it's 20 years, but from 1 to 20 years old versus 20 to 40, it's quite different. And there's a lot of molding that goes on. Well, you also have to deal with behavior management, and an initial exam is usually the first exam, and it's one of the most important exams because that can determine a child's make or break experience, and it can follow them all the way to adulthood. There's something also called the Frankel Behavior Scale. I know there's a lot of scales and categories that we'll talk about in this chapter, but in the Frankel Behavior Scale, they use it to measure the behavior of the pediatric patient. So it's a scale from 1 to 4. So when you have 1, it's definitely negative. And if you have a scale of 2, they exhibit negative behavior. And then 3, it's positive. And on a scale of 4, it's definitely positive. This I took directly from your textbook. It's just what I said in the previous slide is basically a summary of what they are mentioning in the table in this chapter. And it gives you a little bit of like more examples. Like, for example, if you're definitely positive, there's a good rapport with the dentist. The patient's interested in the procedures, they're laughing, enjoying. But when you go to something definitely negative, there's a refusal of treatment, they're crying, they're fearful, and there's extreme negativism. So there's something to think about when it comes to that. There's examples of ways to include a young child in a procedure. You can have the child select the type of eyewear. They can point to the tooth you would like to start with. They have the child point to the tooth that was smiling for the camera. So it really deals with the child getting involved with the procedure. It makes them feel a part of it. So that way there's less fear. No matter what, there's guidelines you should always follow when you're dealing with the pediatric patient. You want to always be honest with the child. Don't lie, okay? You want to consider the child's point of view. Remember, we're developing trust. You always want to use the tell, show, do technique, okay? And you always want to give positive reinforcement. But then again, we always have a challenging patient. And with the challenging patient, some patients, despite our best efforts, they cannot and will not cooperate. So there's a use of restraint. So it could be a physical restraint, it could be a pharmacological restraint. Now, pharmacological restraint is more of like medicine, like you have to give medicine to the patient to make them drowsy or to kind of make them calm down. With physical restraint, I don't see this often, but in the past, they've used something called like papoose boards, something that can prevent them from harming themselves or moving their arms around and legs around, because that can harm themselves while the provider is giving treatment to the patient. Okay, so these are things you can talk about, or rather think about, when you're dealing with those two terms. Now, with the pharmacological aspect, we're just going a little bit more in depth. We have a nitrous oxide or oxygen sedation method, and that's part of, I believe, one of your proficiencies that you have to complete in 2 of the courses. So this method is usually mild sedation, and in general, people used to call it laughing gas, but it kind of makes the patient more relaxed. But overall, sedation in and of itself is used to calm the patient and put him or her at ease before the treatment. And then, of course, physical restraint, you want to prevent injury to the child and the dental team. And here's an example of that papoose board that we have here. And these are basically straps, and they're like strong, powerful straps. The child would lay down here, and you would basically take these straps and strap them to it so that they don't harm themselves. And here's an example of the nitrous oxide that is being performed on a child. Okay. Now, I mentioned earlier that special needs also plays in effect with this chapter. So patients with special needs can be challenging. There are mental and physical disorders that could serve as a challenge to the child, the parents, and the dental office. Often a pediatric practice will suit a child with special needs better than a general practice, okay? And often patient care is carried out in the dental office, but it's more for challenging situations, and they may need a hospital setting. There's only so much a pediatric dental office can do. Ultimately, sometimes they have to go to a hospital setting. Okay, so patients who have or at increased risk for a chronic condition, they'll need dental services that, as required by those in the general population, but they're not limited to just children, right? So we have to deal with the physical aspect, the developmental aspect, behavior, and emotional aspect. So just some statistics here. So there's around 12 million US children are considered special needs, and which is 18% of all the US children in the population. That's quite a big percentage. And it's estimated that 25% of children treated in the pediatric offices have special needs. That's a quarter. The gender is the strongest predictor of special healthcare needs because 60% of the kids with special healthcare needs are male and 30% are girls. So families with income below a federal poverty level are a third more likely to have children with special healthcare needs. So when you want to evaluate someone with special needs, you want to consider the pre-treatment evaluation, and that can prevent over 90% of life-threatening situations. Of course, you might remember the ASA categorization that you were kind of exposed to that in radiology when you had to categorize the patient based on their ASA classification. Also, the information from parents and caregivers is really important. Maybe even one of the most important parts to the special needs evaluation, because they themselves have worked with the child. They themselves are really exposed to the child. They know when, they know what could pose a problem. They have the best rapport with the patient also. I remember treating a patient in the past, and the parent would know when the patient would be having a seizure, for example. And I asked the parent, how do you know that, your child is having a seizure? And she couldn't explain it. She basically said it's like she has this look on her face right before she's about to have a seizure. And it was very helpful because the parent would sit in on the procedures and immediately tell us that, the patient is about to have her child is about to have a seizure. Don't forget, there's also a physical exam and a laboratory exam, and of course, a medical consultation form. There are some observations when you're looking at patients. For example, they're walking. You want to look at their gait. How are they walking? You want to look at whether they're making eye contact with you or not, because if they're not, it could be a sign of having a patient be autistic. And then also shaking hands. Let's say their hands are shaky. Maybe they're clammy. Maybe they're, exhibiting anxiety, and also breathing sounds. That could kind of show that the patient has asthma. So, what are some of the strategies we want to think about? You want to keep an open mind, and you always want to be willing to listen. Again, we're not here to judge. We don't judge our patients, nor the parents, nor the caregivers. We're always looking at it from an objective lens. You want to demonstrate confidence in enlisting patient expertise and be prepared in case there is a medical emergency, because you never know. But with a mentally challenged patient, there's an intellectual disability, often abbreviated as ID. And those are those with limitations in intelligence, adaptive learning, and home care skills. And it determines the need for the dental care, office care, hospital care, or even if the patient has to go through an institutional setting. So those with mental challenges are categorized into 4 groups. So when it deals with the intellectual impairment, there's again a couple of categories. So with the intelligence quotient, or IQ, the mild range, or the mild category, is IQs ranging from 50 to 70. That's when you learn functional skills at an early age, and you'll often do well as a dental patient. The challenges may appear later as the gap widens with their peers, and maybe they need extra patience when they want to comprehend or understand certain procedures. And then, of course, there's the moderate category, and the IQs are ranging from 35 to 55, right? So it's a little bit lower. They may need supervision and guidance, okay? And they don't usually progress past the 2nd grade level. They can benefit from vocational training, but dentally, they may be more challenging, and they might need additional restraints to complete dental work in order to get their dental work completed. And then, of course, there's the severe IQ range and the profound IQ range. The severe IQ range ranges from 20 to 40. They've got poor motor skills, literal communication skills, and they probably, even with the simple tasks, they need supervision. They need supervision with the adults or maybe another caregiver. They may even need general anesthesia to complete their treatment. And then with the profound, it's below 20. Their IQ is below 20, and there's minimal capacity for functioning. Very structured. You need a very structured environment and specialized dental care. Down syndrome. Some of you may be going to your externship offices and may see patients with Down syndrome, and they're characterized by an extra chromosome, okay, which is chromosome number 21. And Down syndrome could also be termed as trisomy 21. Trisomy 21. Their physical characteristics are usually their eyes are slanted, almond-shaped eyes, short bridge of the nose, maybe shorter stature, and they often have heart problems. Their abnormalities in dental development may be present, and maybe even some periodontal problems. Autism is another issue. Developmental disorders characterized by processing disorder in the brain. They often have poor social skills. There is a lack of interpersonal relationships, poor organization skills, maybe even poor speech and language development. But they do have a wide range of skills. They can range from poor to high functioning. And many have behavioral management problems, and they might even be on medication. Now, when you consider medication, you often have to think about xerostomia or dry mouth, because that could be a side effect. Cerebral palsy is basically a non-progressive neurological disease. It's characterized by brain damage that causes paralysis, maybe even muscle weakness, motor function weakness, and maybe even a lack of coordination. There's also types of motor disturbance, like spasticity. They may come off spastic, like an exaggerated stretch reflex, athetosis, or uncontrolled involuntary movements, maybe even drooling or speech defects. So what is the home care for someone that has such spasticity or someone that has cerebral palsy? So, they may have poor home care on their part because they don't have good dexterity. So, you often have to give home care instruction or HCI for a caregiver so that they can help. An electric toothbrush may help because it doesn't involve moving the toothbrush as much. But no matter what, we have to have consistent dental maintenance appointments. Patients can't always communicate their needs, so it's difficult to interpret dental discomfort. It's hard for them to communicate. Pre-medication may also be needed to relax the patient. Diagnosis and treatment planning for pediatric patients overall, though, the first appointment should take place around what, 1 year old? And then you have to introduce the child to the office. Regular exams should start around age 2, and there should be no treatment, of course, without permission from a parent or legal guardian. A good medical and dental history is definitely mandatory. You want to know when was the last time patients were hospitalized, when was the last time they had any type of surgery, any type of last medical visit, what are medications or allergies that they have, any problems at birth, what is the level of learning, and what is the main concern about their dental health. Habits such as pacifiers or thumb sucking or finger habits is also really important. Any habits with the toothbrush or fluoride, and did they inherit any family dental characteristics? And some of that could be anywhere from missing teeth to congenitally abnormal looking teeth. So initial clinical exam, this may be a summary in the past for you guys, but the initial clinical exam deals with the radiographic imaging, which depends on maturity, extraoral exam, an intraoral soft tissue exam, examination and charting of the teeth overall. Are there any spaces, any decay or caries? And again, any habits. This is what an example of dental report card looks like. And, the report card would have anywhere from like their orthodontic evaluation, what is their current status, you'll have the date, what is the treatment performed, a plaque score. So lots of information, whether it's digital or on the form, could be present. But overall, when it comes to prevention, you have to consider their oral hygiene, any fluoride, and also diet. So oral hygiene, are they doing their visits twice a year? How often are they brushing and flossing? And with fluoride, sometimes where do they live, right? So is the water supply that they have, is it fluoridated or not? Are they taking any supplements? What kind of toothpaste are they using? There is some debate about using fluoride nowadays, so you may want to ask the parent, is it fluoridated toothpaste or not? And also their diet. Are they putting the child to bed with a bottle? Are they limiting sweets? So, are they having any sticky foods? So something you want to talk about or communicate with the caregiver or parents. Another thing you have to consider are sealants. So you remember sealants. So these are applied to pits and fissures. So does the child have any sealants? Do they need them? Any orofacial developmental issues like malocclusions? Were there any congenital malformations? Any oral habits? I repeat that over and over again, but it is a very common occurrence of oral habit issues with children. You also want to consider any preventive orthodontics or interceptive orthodontics, meaning Do they have a mouth guard, or rather, do they have a permanent retainer in their mouth, or do they use a retainer? Sports safety is where we're talking about the mouth guards or any protective equipment that the child should use or might be currently using to prevent any injury to the mouth when they're playing any sports. This is an example of a space maintainer. So some children lose teeth early in life. So what they have to do is they have to keep the space maintained, because what will happen is the permanent tooth will erupt in the place of the primary tooth that was lost. And you don't want that. You want to make sure that the space doesn't get crowded uh, in order to prevent a permanent tooth from erupting. So those are space maintainers. And sometimes we have appliances like this on the upper teeth, because we want to consider any issues with like palatal expansion. Okay, maybe we want to expand the roof of the mouth a little bit. So lots of things come into play. Pediatric procedures, you'll remember that there is a matrix system, although we used matrix bands. In the pediatric procedures, they use T-bands or spot welded bands, custom bands that adapt well to the wider primary teeth. Remember, primary teeth look a little bit more different than the permanent teeth. When you look at your typodonts or your dental kits, the permanent teeth, the necks are more narrow, but with the primary teeth, you'll learn that the necks of the teeth tend to be more bulkier or wider as you go up the buccal surface onto the occlusal surface. When you think of endodontic procedures, they're a little bit different than the permanent teeth. With primary teeth, you have something called pulpotherapy. We talked a little bit about this before, but we want to always preserve the primary teeth as much as we can because it acts as a good space maintainer. There's indirect pulp capping and direct pulp capping. What is the cause of pulpotherapy? Well, decay or maybe even trauma. So pulpotomy is basically the removal of the coronal portion of the pulp. So if you remember for DNA108, there was a radicular portion of your pulp or nerve, or the coronal portion of the pulp or your nerve. The coronal part was like more towards in the crown, more confined to the crown. So pulpotomy deals with you're just basically scooping out the coronal portion of the pulp. Okay. If you're dealing with the formocresol pulpotomy, you have to put a little bit of formaldehyde, a 50-50 formaldehyde cresol ratio, and it's usually preserved in glycerin. It comes in a bottle, and you kind of soak up a little bit of the cotton pellet in there, and you put it into the tooth for a little while. And basically, what's the concept is the formaldehyde kills the pulp. Okay, and then of course you do have calcium hydroxide, and that's primarily for young permanent teeth. With the apex that's open a little bit, and the pulpal exposure are often due to injuries to stimulate the root to develop with root canals later. So you'll fill it up with calcium hydroxide in the permanent teeth. Just you don't want to you don't want to finish the root canal. You want to keep it kind of temporary for a while so that the apices close up, so that when the child gets older, the tooth can get a more permanent root canal, and then that's more effective. For a pulpotomy, you can see the setup tray here. You'll see the zinc oxide eugenol here. You'll see anesthetic here. But no matter what, you want local anesthesia. You want your basic setup, a dental dam, your hand pieces and burrs. You want your instruments. And you don't want to forget the formocresol and the zinc oxide eugenol. You want the cotton pellets and any type of restorative materials like a stainless steel crown ready to go. But the pulpotomy procedure in detail, your book goes into it a little bit. You always want to make sure the patient's numb, right? So you got to give local anesthesia, and you want to then place the dental dam on top of the mouth. Then you want to access the tooth with a round burr. After you access it, you drill it a little bit and you expose the nerve. You use a spoon excavator just to remove the decay, or rather the coronal portion or the coronal pulpal tissue. Then you want to get your cotton pellets, okay, and just kind of moisten it a little bit with the formocresol. Place it in that area for 5 minutes, just so like you can control the bleeding. Now, this is similar to the hemodin, if you remember, but it's not the same thing, but it's kind of similar to that. Once the bleeding is stopped, then you take out the ZOE filling with a drop of the formocresol, and you place the final restoration over the ZOE base. And then, of course, you always want to document all the stuff you did so that another provider that opens up the tooth in the future knows exactly what's inside and what was done. And here's just a cartoon version. You see that you access it with a round burr. You want to kind of take out the, the coronal portion of the nerve or the pulp. Then you want to form a Cresol cotton pellet for a little bit, then remove it, and then put your ZOE cement on top. Stainless steel crown. Some doctors definitely put a stainless steel crown on top of the primary tooth when there's not many walls left or when the decay has really eaten up the tooth. Okay. And again, it's temporary, just waiting for that permanent tooth to grow in. Okay. Usually done in one appointment. So the stainless steel crown procedure setup is usually you have a basic setup. You want to get the patient numb with local anesthesia, dental dam, and make sure the crown is ready. You want the crown and bridge scissors and the crimping pliers ready. Maybe even some finishing stones and discs, and then of course the cementation setup. Okay, I'm going to leave this YouTube video here for you to look on your own. Please look at that. That will help you out in how you place the crowns, okay, and some of the procedures that are entailed with it. But overall, you want to look at like the overall general thing. I think this is also present in your textbook in one of the featured papers. I think it's the pages, the purple pages. Again, you want to trim the crown to reduce the height. You want to smoothen the edges with your stone, and then maybe even use the crimping pliers to crimp it so you can pop this on the stainless steel crown onto the tooth. Once you cement it in, you want to floss it down and pull it out from the sides, okay, to remove any excess cement. If you have to, you can still continue to use the crimping pliers to continue to crimp the tooth. Maybe you don't feel like it's a good snug fit. Former Cresol is a mixture, like I said before, formalin, Cresol, and glycerin, and it's used for a vital pulpotomy. Okay? And you want to use it as a temporary intracanal medication when you're in the middle of a root canal therapy. Okay? So it's more considered as a disinfecting tool, and you want to maybe deaden the tooth. Dental trauma in children, oftentimes we have these kids that are going out playing sports. They come back with fractured anterior teeth. They'll present with traumatic intrusion, meaning the tooth got stuck inside the mouth, got pushed in. Extrusion, maybe it fell out or it got loosened, or maybe even avulsed teeth, it completely came out. You want to educate the school personnel about dental emergencies. It's always important that there's that open line of communication when it comes to first aid for dental emergencies. Oftentimes, if a tooth fell out, what will happen is that the child wants to throw away the tooth, or maybe the nurse doesn't really know. So it's important to keep that educational line going with the school nurse or maybe with the personnel in the school. Fractured anterior teeth, very common, especially in sports or even when a child falls. As soon as you see that happen, definitely the school should call for an emergency visit. There should be an immediate clinical exam. Don't wait. Protect the pulp by placing a temporary filling in it. Delay the final treatment until like 3 to 6 weeks to see how the tooth reacts. And then follow up with radiographs or maybe even use the pulp tester to see, is this tooth vital or not? Intrusion, well, we saw the fracture in the previous slide, but the traumatic intrusion is when the tooth has been pushed in. So you see this has been pushed in. So you really can't do much for it. You want the tooth to erupt naturally, but it could be so that the permanent tooth underneath, like if this is a baby tooth, the permanent tooth may be damaged, or if this is the permanent tooth in and of itself, it might have been damaged also, and it might need a root canal at a later date. This is an avulsion where the two teeth have come out completely. So that's called an avulsed tooth or an avulsion. Okay, extrusion or lateral luxation. Sometimes the patient falls, and if they fall, or let's say there's some trauma that happened, the teeth actually got pushed laterally. So lateral luxation. Teeth are displaced from their position. It's caused damage to the periodontal ligament. Okay, so there's a displacement. So sometimes, okay, so what you want to do is you want to put the teeth right back into place, because obviously these are a little loose. So you want to push them back into place in this case, and then place like a temporary splint. Okay, and that's usually like a little band you put here with composite. You wash up the area, clean the area, put a band there, connect it from this tooth to this tooth so that the teeth kind of stay in position. And then after maybe, let's say, a month or a month and a half, you want to remove the splint to see if the patient's teeth have stabilized to some point. In the end of the day, we can't leave the splint there forever because if you do, you run the risk of the teeth being ankylosed. And ankylosed means the teeth have now been fused to the bone, and that's not what you want. Okay. I talked a little bit about the avulsed teeth. The avulsed teeth, when the teeth are completely knocked out by force, you want to recover the tooth immediately. Go get it, even if it's in the dirt, go get it. Wrap the tooth in a moistened gauze or moistened napkin. Go to the dentist's office with it. The sooner one can be seen, the better the chances of the success of the tooth within 30 minutes. Wash the tooth with saline. Don't clean it, just rinse it. Leave the fibers attached and put it back into the mouth. Splint the tooth in place and return to 6 to 8 weeks. Yeah, believe it or not, you got to put that back. You got a very short amount of time or like a short time window where there's a success rate. After that, it dramatically goes down. Okay, is your avulsed tooth? Child abuse. Okay, so, I know I showed you pretty graphic pictures, but do know there's child abuse exists. Okay, and then, in all 50 states, healthcare professionals, which are you and I, healthcare professionals are required to report any case of suspected child abuse. There is CPS, Child Protective Services, in state or county. The dental assistants are not legally required to report abuse, but ethically, you should report it to the dentist, ethically. The name of the person who reports it will not be revealed. You are doing a justice to the patient because that is not right that the patient is being subjected to this abuse. You may be a hero. You may save a life. Suspected injuries. Please know that there's injuries in various stages of healing. Teeth are chipped, injured. The child has scars or tears inside the lips or on the tongue. They can exhibit battering or other injuries around the head and neck. They can have facial bruises, swelling of the facial structures, black eyes. The child may, believe it or not, might even sadly have bite marks. So the injuries are not consistent with the explanation presented by the parent. Like something is not making sense. Please be on the lookout for that. Now, I'm not saying every little thing, okay, yeah, let's just go suspect everything of injuries. Just be very wary of that. Reporting child abuse, the required information when you report the child abuse, you got to know the name, the address of the patient, the sex of the patient, the age, the height and weight, the name and address of the adult with the custody of the child. These are things that could easily be found in the dental charts. You want the description of the current physical or the emotional abuse or the neglect of the child. You want evidence of previous injuries or negligence, any information that may assist in establishing the cause of the injuries. You maybe even sketches or photographs in documenting the nature and location of the injuries can be a huge help, huge help. This is just something that's already in your textbook that we mentioned. And of course, I do want you to review the wonderful colored pages in the textbook, which is procedures 57-1 and 57-2. And these are my references. Okay, thank you. And while we're on, thanks for listening to this. Let's go ahead and look into, I can find it. Let's look into just the armamentarium. I just wanted to review this. I just remembered that I have this right here. And this is uploaded on your Canvas site. It's just some general pedodontic instruments. So for pulpotomy and stainless steel crown placement, these are very helpful to know. The spoon excavator, pharmacresol, the pellets, the ZOE, the stainless steel crown, crimping pliers, the scissors, and the Howie pliers, okay? So the armamentarium is very helpful for you guys to know, especially for those of you that would like to go into ortho or that would like to go into pediatrics. This is really helpful to know. So I just wanted to show you this for your own reference. Okay. Okay. Thank you.